all. It's me again. I'll be quick. I have about only 5 slides, so I'm not holding you for the receptions. So I wanted to touch base on patients and caregiver education in the outpatients focus. And this slide is heavy. And when I was trying to reword this, I guess I will leave it intentionally. And because that's how our patients feel. We are absorbing all of the information that we have today, and we're also giving those information to our patients and caregiver. And it's really heavy. And RT therapy is not like our patients are used to in terms of the chemotherapy and stuff. This is complex process. This is a live therapy that we're giving, and it has a long process. So I wanted to highlight, why do we give outpatients, right? In our City of Hope, our default is outpatients, and our loads are actually heavier in the outpatient setting. So I'm coming from inpatient setting. Now I'm in the outpatient setting, and it's make me very, very nervous to send patients home if they live close by. And if they're staying in a hotel, still, I can't see them. I am putting these trust and everything's in the patient's and the family hands. So we really need to have the thought process to go into when we determine the patients who's going to be receiving in the outpatient setting. So it really is a collaborative of efforts, and many thoughts are going into how and who will get the products in the outpatient settings. So some of the factors that we include are disease burdens, and also some of our clinical trial patients, so products-based, and patients' levels of social and family supports that we consider, because some of the patients are just not safe to receive care in the outpatient setting. And also, before this program go live, we really have to have these administration requirements, stringent institutional trainings to provide these necessary and very important training to our personnel. And these including patients, caregivers, physicians, including our on-call physicians, advanced practice providers, nurses, clinical staff, and infusion centers and emergency department personnel, which is our ETC here that we have, to ensure that these people who are not taking care of CAR T patients in everyday basis, but they will come across taking care of them at that needs. So safeguards has to be in place. So the goal is to swiftly manage the toxicity and also intervene certain problems, unforeseen challenges that we learn along the way. So it really is a multidisciplinary team approach to deliver this. So this is more of a simplified way to look at it. And these are all not exhausted list of people that involved. We have physicians, APP, both standard of care, nurse coordinators, and our CRNs that we heard about from today, coordinators, our pharmacists, our stem cell processing team. We also have our social works. They play a key role in helping out and then making sure that patients' needs are met. And also industry and regulatory guidelines, and also our own internal clinical cellular immunotherapy committees. So that's CCIC that Dr. Buddies mentioned. We meet weekly and we discuss cases, patients who potentially could get CAR T, whether inpatient, outpatients, clinical trials, so forth. And we also run the list for whoever inpatients and outpatient patient lists, and we keep an eye out. So it really is a collective approach and also collective decision. In the cellular collections phase and manufacturing process, the patients will encounter a lot of our procedures team. So their line placement team, they will get their CAR T workup, so their imaging centers that we'll see. So they will encounter many personnel throughout the time. And we cannot deliver education at one point, but we will have to have education at each touch points, because they will have a lot of questions, confusions, and we practically, when we first started education, we give them this many pages of educations. And I will show you the timeline when they first get that CAR T cell educations. And once we get cell infusion and ongoing monitoring and management phase, we have our ambulatory folks and inpatient care teams, because these patients may start the treatment in the outpatient setting, but they may actually go into inpatients when they develop CRS and ICANS. And we have to have a clear communication lines in our on-call physicians and again, emergency personnel. So let's put all together what we learned today and in a case. So this is a patient, Mr. Z, 62 years old with the relapse refractory ALL patients. So his primary hematologist and him decided that his next lines of treatments will be a CAR T cell therapy. So when it's first that decision is made, the pointer doesn't work. It starts with the referrer. So the hematologist will bring his case to RCCIC committee, and he will present the case. The committee then decides, agreed on the products and also recommendations. And once that's happened, the patient is referred to our standard of care or the research site's CAR T coordinator. That coordinators can kind of start the ball rolling with every coordinations. We also refer a patient to a clinical social works with advanced care planning. And the education happens with the start with our CAR T coordinators, and that can be also from the research sites as well. So, and if we think about the timeline, the cell's going to be infused 3 weeks from now when after manufacturers. We start educations at 3 weeks time frame. Patients are not going to remember a lot of information. They're also overwhelmed, and these CAR T education process, these are very complex informations. So bear that in mind that we need to reinforce these educations throughout these touch points. During this cell collections, patients will encounter with these nurses who will check the veins to make sure do they need a line to have a cell collections. And if they do, they don't have a good veins, we will then place a temporary lines for cell collections, and then we remove these lines. Patients at this point are patients. Went on and meet with the social works, with the caregivers to make sure that any necessary needs that they may have. At that point also, they will have to identify a caregiver who will be responsible for caring and providing transportations throughout the CAR T cell therapy journey. Our CAR T coordinators then create a CAR T cell schedule, LD schedule, and once they're gonna get cells transfused. And while the cells are manufacturing, the patients may go through all these pre-CAR T workups, including these MRI, brain, PET scans. So patients will then encounter with a lot of these departments personnel, and they may also undergo bridging therapy at that point while they're waiting for the cells. RN coordinators play a key role, so they communicate with our manufacturers, and then when the cells are arrived, we coordinate for the PICC line insertions or any other line they may need, and then patients then goes on to get MD visit, and that's where our cell infusions, our LDs and cell infusions treatment starts. During that process, the patients probably already forget about what they've been educated at 3 weeks ago. So we need to reinforce, and also they may have some changes in their personal life. So their caregiver that they identified early on might not be available. So things like that we have to address. And many of these back and forth coordinations happen between the patient's family members and RN care coordinators. During that point, the patients will come to our day hospital to receive lymphodepletions and also the cell infusions. They then get additional education package to orient our day hospital workflows and things like that. So patients has a lot of information that they have to absorb. Main things that we highlight is, again, to have a caregiver 24/7, no driving, having to stay locally, but a lot of times these local stay arrangement has been done and coordinated by our care coordinator as well. Once the patients got admitted to our day hospital team, we re-educate these and reinforce these education needs and touch points. And our main goal will be that, do they know when to seek care? So they need to make sure that they have thermometers to monitor the tick fevers, recognizing the subtle changes, neurological changes, so that they can seek care early on. So this is the whole process that I go through. And on the right side is the wallet card that we were mentioning. So this is from our Yaskar and Takata's wallet card. So we want to make sure that the patients and family members have access to that. So again, this is overwhelming list, but this is the list that we cover for every single patient. And in your handout book is lists all the information that we hand out to our patients. And it is a lot of information. And this goal as to how food safety guides. And many of our patients coming from other states, they may not familiar with the area. They also don't know how to get food and support. So we wanted to address these because I have had patients who prepare meal for 14 days straight, thinking that they are going to be in the local state for 14 days. And by the time the patients develop CRS at day 3 and 4 and get admitted, and now they don't know what to do with those foods, with 14 days worth of foods in the hotel. Okay. So other cases that we encounter are like when we say 24/7, some people think that, oh, I can work from home and that can happen, but at the same time, you actually really need to monitor patients and being aware of these symptoms. So these are challenges that we face along the line. Now, these are timelines that we generally follow. So our patients who presented to our day hospital for lymphodepletions, he had forgotten that he needs to show up to a day hospital every day for her chemotherapy. So that was one point at day -5. Now he shows up to our day hospital every day, and by the time I believe day 2 or 3, he didn't show up with his wife. His nephew came. So we were all worried because we have not provided an education to a nephew. He didn't know that he's supposed to be watching for fevers or neurotox. So these are challenges that we face. And by the time day 6, the patients developed a fever. He presented to our ETC, and he was told that he's going to be admitted to the hospital. Now he argued with us that, okay, I have no fever at the moment. Can I go back to the hotel because I have more freedoms? A lot of time, these kind of little things that patients' understandings, we wanted to support and re-educate along this line. And by the time they get to go home at week 2 or week 3, they also forget that they cannot drive for 8 weeks. So we have to reinforce, and that's been many times we have to reinforce. They were like, what? I cannot drive? So a lot of these are challenges that we face with the education. But now when I educate the patients, and also all of us that encounter patients during the process of what we consider is health literacy, so, because CAR-T really is a complex process that need re-educations. We may need to give multimodalities like written informations, videos, things like that. We have to consider caregiver fatigue and burned out. After all, they are there 24/7. And a lot of time, what I heard from the caregiver is that when the patients do develop neurotox, it was very surprising for them. When we keep saying neurotox, there are times where patient can just, one day they're awake and the next day they stop talking to you. So those are the days that, those are things that we wanted to support, re-educate the patients and the family, and then be there for them. Consistent caregiver availability. When we ask someone to be there with the patients for 24/7 for 2 weeks, it's not feasible for a lot of family members. So their planning process, they might be thinking that I'm going to switch up with so-and-so. But from our provider standpoint, we need to make sure that we educate every single caregiver, because continuity is important, and they need to be able to recognize that. We had, in our facility, we had tried paid caregiver for those folks who do not have as family support, and that has been a challenge, and that's an opportunity for us to work on, because sometimes paid caregivers, they do not know what to watch for. There's a continuity of care involvement, so these are things to be considered in the planning phases. Navigating the healthcare system, even within our City of Hope, we have many places that the patients need to go. And it's each touch points, we have our own way of doing things, and patients get frustrated, and we want to make sure that we as the providers to be consistent and also understand and be in patients' shoes and understand them. Burden associated with the additional support care and appointments. So a lot of time we tell them that you come see our providers, get, just to check for your CRS and ICANS and go back to hotel. But it's never the case in some of the patients where they might have to come back for transfusions, hydrations, and their days might be spent the whole day at the day hospital getting those care. So that can be a challenges as well. Lodgings and it does come with a financial burden, so we wanted to consider that. And some of the patients, they may plan to go back to, wherever they come from, Oregon or Connecticut, and we have patients coming from Hawaii, they book the flights for 2 weeks, 3 weeks. Now they have ICANS and they cannot go home. Then we have to consider those. And they may actually need an alternative care, meaning they have to go to acute rehab, for example, because they've been on the steroids and now they need to replan their life. So these are the challenges that we faced, and I wanted to make sure that we are mindful of this. With that, I conclude my presentations. Thank you.